We're first learning about the pathophysiology and so forth because now we have functional imaging studies to help us with that. But I would say in some ways the location of the pain is a bit different. So we know that with cortical spreading depression, we think there's some abnormal electrical activity in one part of the brain that then propagates. It's like a wave of electrical activity. It causes release of something, neuropeptides like the calcitonin gene-related peptide and some other things. And so then we have activation of the trigeminal vascular complex and causing pain and affecting the brain stem, which is the lower part of the brain. I think that's different in some ways than cluster headache because with cluster headache, other parts of the brain are lighting up, for example, on the fMRI studies. But it's really, people have been working on it for a really long time and doing great work, but I would say that we're at the point where we're finally getting to learn that. And there's a lot of psychiatric comorbidity with migraine. We have anxiety, depression, sleep issues, post-traumatic stress disorder, abuse, even bipolar disorder, and some other psychiatric disorders. The prevalence is quite high. About 40% of patients with migraine suffer from depression. Some studies have more in terms of the percentages, some have less. And anxiety is actually even more prevalent. Some studies show that even up to like 51 to 58% of migraineurs suffer from some sort of anxiety disorder, and that could be generalized anxiety disorder, that could be panic attacks, that could be a specific phobia. The list is extensive. It's actually a significant public health problem because the healthcare cost of these patients is much greater. It's actually about 1.5 times for migraineurs with psychiatric comorbidity than those without. So it's a big public health problem. It's also really challenging for the patients and for the physicians because those who have psychiatric comorbidities, they actually have more difficult to treat migraines. So it's a really important consideration when we're seeing patients who suffer from depression and anxiety and these other ones to really address that. There were studies done that found that there's a bidirectional relationship, for example, between migraine and depression. There was another study done that found that patients first developed anxiety, then developed migraine, and then developed depression in terms of the temporality. But it's really hard to say, actually, because I always tell patients it's one brain, so it's really one organ. And some of the same neurotransmitters are implicated in both disorders. So serotonin is affected in migraine. We know that from the medications that we use, like the triptans, the migraine-specific medications that we use, affect serotonin levels. Similarly, we know that in depression and anxiety, serotonin is implicated. So we know serotonin is related. We also think that probably norepinephrine and dopamine are related. And so it's really, one organ that's controlling these things, and so it's hard to really say. So it's a really interesting topic of patients going to the emergency room for, saying that they have a headache and sometimes asking for opioids. And I think it's really a two-part issue. One is patients may request opioids, and it puts the doctors in a predicament because, of course, there are always patients who are drug-seeking, unfortunately, in society. And so it's hard for the doctors and it's hard for the patients because you also have some patients who really legitimately have severe migraines, and they've been through lots of different medications, and they will specifically sometimes ask for certain medications, including opioids. So I think that it's really a difficult situation. In my particular practice, I'm mainly really doing outpatient, so I don't experience it so much. What I experience more is that patients come already on opioids to me, asking me to continue their opioids, and honestly, opioids really are not the treatment of choice for migraine. They're not the treatment of choice because there's actually been no randomized controlled trial for efficacy, looking for effectiveness, that have found that that they're effective for acute treatment in migraine. And then there's also, unfortunately, issues where we have patients who are multi-sourcing scripts and getting opioids from different places and using them for the wrong things. So obviously there are tons of patients out there who are completely honest and just in a lot of pain and need good treatment, but opioids really have not been shown to be the effective treatment for migraine.